All right. Welcome, welcome. All right. Take it away, Teresa.
Hello, everyone. Welcome to today's Journal Club. Briefly, we'll be discussing a randomized placebo-controlled trial, which is completely different from last month's basic science research study. Leading our discussion today is Dr. Phil Molloy, a rheumatologist who continues to be active in caring for patients despite retiring, and Dr. Jahan Marcu, a cannabinoid researcher and owner of Delaware Analytical Research Lab in Delaware. Dr. Len Kamen may join us. Right now, he's probably seeing patients at Moss Rehab Outpatient Center in Philadelphia. Next slide. For those of you new to our program, I'm the CEO of Physicians Research Center Plus. It has three areas of expertise. SALIS is our phase 2 through 4 clinical study pillar. Buds Info is our analytics pillar, and Cerium is our education pillar here at PRC. And Cerium is designed for the busy healthcare provider who wants to understand cannabis and its derivatives through the lens of science. Check out our website listed here at the bottom if you want to learn more about PRC Trials Plus. And also, you can access our free educational blogs on the site. Next slide. Okay, I'm going to hand it over to Jahan.
Hello, everyone. The mission and vision of the Cerium Journal Club is to support the education of healthcare professionals with discussions of published research, and we really try our best to approach each paper with consistency, fairness, and transparency. Quick note, please share this journal club link or however you got here with your interested colleagues. That's the same link every month, first Tuesday at noon. So put it in your calendar, put it in their calendar, and invite any of your healthcare professional colleagues who might be interested. Again, we want to just emphasize that the purpose of this journal club is to educate and raise awareness. We're not recommending any policy or regulatory decisions. And with that, hear ye, hear ye. The purpose, again, is to educate and raise awareness, engaging in a professional exchange. We're talking about the data here about in the paper. We're not looking at policy or regulatory decisions or have an agenda here other than education. And now, after that disclaimer, I hand it
Yeah,
off to Dr. Molloy. Phil, um,
sure, sure. For anyone listening who has history of attending prior journal clubs from Cerium, I just would like to remind us all that in about a year and a half ago, we talked about pain and cannabis in a review article. So there's a reference of what we did in May of 2024. Pain is a common topic in the cannabis literature, and it's worth revisiting again, especially when there's new interesting publications that might be important. Jahan, is this archived if anybody wants to look at
yeah,
this
we
within the club?
have on YouTube, if you look for the Cerium Journal Clubs, you should be able to find them.
All right,
Um, yeah, we'll be posting a blog on the PRC website that contains links
all
to
right,
these studies
good, good.
or
Let's
to
go to the
these
next
Journal
one
Club
then.
videos. Yeah.
Yep. Well, this is pretty self-explanatory. Who hasn't? Everyone that's taking care of patients has heard some of these things. Doctor, should I try cannabis for my pain? I've tried other things that haven't worked. My neighbor, my relative, my whatever, my gym friend, um, trying cannabis. So you can't be in this space without coming across, does cannabis really have a role for pain? And what do we know about it? And on the left, you see pain is the number one reason that people use that have medical cards.
Yeah.
Um,
And it's also the number one reason all of my relatives contact me about any CBD, THC product. They're like, will this help with my arthritis? Will this help with my back pain? Will this help with your sister-in-law's pain? Will it help? It's, I feel
my
like it's the
dog.
number one family discussion people ask me about is research
Yep.
in this
And
area.
you can imagine what the life of a rheumatologist is in this taking care of people with aches and pains. That's what leads them to our offices in the first place. If they're not asking, they're thinking of it and just not saying it. Yes. Okay. So this is an article, and on the left, I'm tempting you. Have you heard of this article? Either in the lay press, this has received attention in, Washington Post, Wall Street Journal, New York Times, and other lay press, and I'm on a few medical news feeds. So this has come up, and in my world, when I spend time online, I see this. I've seen this article a lot since it was first published a couple of months ago. And you see the title right there: Full Spectrum Extract from Cannabis for Chronic Low Back Pain. Phase three. Usually, you call something a phase three when you're planning to submit it for regulatory approval. Um, Randomized placebo-controlled trial. And that's interesting, don't you think, the title? Because we don't see a lot of
No,
randomized, blinded, placebo-controlled studies.
let alone cannabis products reaching for the rung of federal approval in some form, maybe as a
Right,
prescription medicine.
right. I don't know if it's on the subsequent slide. This was not done in the United States. This was done in Germany. Okay, next one. Why do we care about cannabis in pain? Because a lot of people are not satisfied with what they're currently taking. Surgery, shots, opioids. It's a big problem. There's a desperate need for novel things that work and that are well tolerated. Is cannabis on this list? Does it work and is it well tolerated? So let's see what a randomized control study says.
And this study caught our attention for a number of reasons, including there's more than 800 chronic pain patients. Definitely the novel whole plant derived product is very interesting, which throughout the rest of this article, I think is codenamed VER-01, VER1 maybe.
Hmm.
And when you see LBP, just remember that is low back pain. Um, and Phil, with your digging and research, I think I was actually surprised to learn that there have been previous studies of this product, and that in a previous study, they actually compared it to another drug, an opioid treatment, and they found that their product had superior efficacy and a better, perhaps, benefit and risk ratio. And now they're going into this interesting design, which uh, I'm looking forward to your discussion about. And at the bottom there is the company's website where you can learn more about them if you wish.
Just looking ahead before we go into the study design, in this study that we're going to talk about today, there is no arm of opioid treated patients. There's a previous independent study by the same group with the same product, and not today.
So, Phil, take us through a bit of the study design.
Well, anybody who has the paper open, like we all do, because it's a complicated study design, there are, as you can see, and we can go over this more, and there is an appendix um, after the last slide that shed some different light on phase A, B, C, and D. So let me just tell you, phase A, everyone, 820 subjects got randomized to a placebo or an active product. We'll say more what this product was on the subsequent slide. Those who completed that 12-week study had the option of using of entering phase B. So not all of them did. The ones who got study fatigue or had side effects or whatever withdrew their consent and said, I'm done. But a majority did go on to phase B, which is an open label extension with retitration. So retitration means you take one dose. If that's not enough, it's dose morning and evening. You can add another dose in the morning, or in the evening, you can titrate the morning or evening dose up into a certain ceiling. So you retitrate, even if you're on the placebo, you retitrate it. You don't know what you're on, of course. Those who completed B had the option, and this was not a random choice. The subjects were offered, do you want 6 more months of open label continuation, or can we talk you into a double blind uh, phase D? So phase D was withdrawing. Remember, if you're on B, you are an open label, you know what you're taking, you know the dose, everybody's on active drug, it's an open label extension with retitration. So picture yourself, I'm done phase B. The study design person or the coordinator says, do you want to continue with the active drug for 6 more months? Or can we talk you into phase D, where you will be randomized to either withdraw, taper yourself off of the active product, or continue it? Let's see how many patients get worse when you withdraw the study drug, looking for side effects and tolerability the whole time. So you can see some numbers down at the bottom. I think the only thing worth pointing out right now is that they carved out as a subset of this 820. This was pre-designed to look at the patients with neuropathic pain versus all others. So neuropathic pain was carved out. I think there's an obvious reason for that. There is a suggestion in the pain cannabis literature right now that neuropathic pain may respond better than other types of pain to cannabis. So it's a confusing study design, but if you look at the paper, you'll see all the arrows and the patients, the numbers that went on from one phase to the next phase. I think the main thing now is that when you complete B, you can choose to go on arm C or D. That's enough for now, I think.
Um, all right, and more on the study design, because you could, patients start in phase A, there's a phase B, there's a phase C, there's a phase D. What are some of the things we should be aware about? Uh,
Well, you're going to take it?
sure.
Yeah,
So
go
in
ahead.
phase
Yeah.
A, if everything goes well, um, you know, patients would move on to phase B. But in phase A, they were allowed to titrate their doses in the AM or PM, basically either, to achieve sort of a sufficient symptom relief with a maximum daily dose of 13 units or vials over their 3-week titration period. There was also rescue medication available. So this is ibuprofen max three 3 days a week at 2,400 milligrams a day. It's basically three 800 milligram pills, or Tylenol. But no other pain relievers or non-pharmacological pain interventions. They kept pain diaries, pain intensity. They had sleep use rescue meds, and there was numeric rating scales and looking at changes from baseline. And what was in these little vials that they were receiving? What was a dose? Good question. Well, each dose delivered 50 microliters of 2.5 milligrams THC, zero point 0.1 milligrams CBG, and zero point 0.02 milligrams CBD orally via syringe, I believe, in sesame oil. And this product was comprehensively characterized. So they knew the cannabinoids, the terpenes, the flavonoids, the carotenes, the phytosterols, the vitamins, fats, and just a lot of quality control for batch to batch consistency. And I imagine that it must have had a real plant like taste to it if it had all those terpenes and carotenes and phytosterols in it.
So this is a whole plant, um, the entourage issue, right? So in the middle bullet, it says how much THC, CBG, and CBD, but that is not a sole list of what's in there, right? Everything else is in there. So dozens and dozens of active products, compounds, right?
Yeah, yeah,
Yeah,
things that are active in the body, pharmacologically active compounds.
yeah.
Now, what they do individually at the amounts they're there, that's up for anyone's guess, but together, I think there is research showing that when you start to combine ingredients, you start to see some interesting effects. So I wonder how intentional developing this to have CBG and CBD in it, even at those small amounts, was. And again, people are taking upwards of a dozen doses of these products.
Yeah, we've seen this feature in study designs in the past and other Cerium articles that we've had, where you're not studying a fixed dose of a medicine like you would for a diabetes pill or cholesterol pill or something, but the subjects are allowed to titrate up or down. We
Yeah,
saw
so
that in
yeah, there
the
were some other
drives.
studies, what they call the ad libitum studies. So people are
Right,
allowed to smoke as much as they want. There are other studies where people have consumed the products of their choosing,
yep,
in amounts of their choosing before doing studies. They've seen this in, I believe it was driving studies, where they had
right,
people use ad libitum and then say, "Oh, hey, I don't feel impaired. Let me go for a simulated drive." And
right.
let's just say they drifted from baseline.
Good.
So, as we mentioned, this study had multiple phases. So, phase A, 25% did not complete. Surprisingly, 14 lacked efficacy, reported efficacy, even though there was this titration for a few weeks that was allowed. 17% experienced adverse events. There was, non-compliance issues. There was physicians' decisions. There were other things happening there, which is, I think, pretty normal for any clinical study. You're going to get some drop. I'd be surprised if nobody dropped out of a clinical study for any reason. Moving, and so phase A was this, blinded placebo-controlled study. Phase B, uh, they all received the product. And so if you passed phase A, then you would all go on the product. And 35% of those people did not complete it. And it's interesting that during the phase B, there was also a report of lack of efficacy. There was a similar rate of adverse events and other reasons for discontinuation. And then from phase B, they split the groups into C and D. C, D, I think that shows up correctly. um,
Yeah.
and C was open label, and D was another placebo versus drug arm. And they looked at a withdrawal phase and changes in baseline and pain scores from there. Moving on to selected outcomes. Phil, Teresa, you want to talk about some outcomes?
Well, um, you can dive deeper in the original paper to look at all the secondary outcomes, but the primary outcome was change from baseline in pain intensity on a numeric rating scale. You call it 0 to 10 is the rating scale, so it's an 11-point scale. And many of the usual secondary endpoints, sleep disturbed by pain and so forth. So some selected outcomes were in phase A. By the way, it did meet its primary endpoint. The change from baseline on an 11-point scale with an active product was minus 1.9, almost 2 points on an 11-point scale down, and zero point 0.6 versus the placebo. And it's statistically significant. And we will be showing a figure, I think, in the next slide or two with some of these graphs about secondary endpoints. In phase D, that was an interesting one because it was a re-randomization. You're going to stay on your active drug or placebo, and let's see um, who flares. And the primary endpoint in D um, was not met. Pain got a lot worse in those who were on the placebo, but it just crossed one on the confidence limit and did not reach statistical significance. There were also signals in phase D, positive signals on the secondary endpoints. But the three figures and the seven tables are in the article to review all this, but we'll show you one of the figures coming up.
More selected results from phase A, as well as B and C. So on the left there, we have TEAE, treatment emergent adverse events for VER01, which is the drug, and PBO, which is placebo. We have SAE, serious adverse events. We have participants satisfied tolerability and actual discontinued to due to AEs. Any comments here, team?
Well, look at this fine point at the bottom of the slide. What were the AEs that caused discontinuations? And the ones you see with an asterisk were statistically significant,
Yeah.
more in the active arm than the placebo. Dizziness, fatigue, nausea, dry mouth, and somnolence were drove that 17.3% versus 3.5%.
Now on to figure three, the uh, the meat of the study, perhaps, as some people might think, as it shows the reported pain intensity scores in the various groups. And so, just to start to get our orientation here, up in the upper right hand corner with figure 3A from this paper, we see the baseline measurement, that titration phase we talked about in blue, where people are using perhaps more, perhaps less. And in blue is the people staying on the drug. And in this gray line here, this is people going from placebo to the drug with another titration phase here. And we see that by week 3, there starts to be some easy to identify differences between the two groups. They start to differentiate here. And then there's another titration phase, and we see that the two groups appear to be nearly identical once both patient groups are on the drug going into the preceding weeks in that year.
Yeah, the right-hand side of that graph is phase B, open label, people on drug. So it makes sense.
Yep. And we,
Graph B, yeah, right below it is absolute change in pain. So how much did the pain go down in the titration phase? It went down significant. You can see the confidence limits on the time points right there. So that's an absolute change in the 11-point scale, 0, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That's it. The bottom graph actually is only pertains to phase D, time period D, where people were randomized to stay on the drug and it was blinded. You didn't know what you were on. And obviously, you see that the gray line had more pain. The people who were on the placebo um, worsened. So they flared when the drug was taken away, and the ones that stayed on the drug have more or less a flat line until the end of the study, W4, where everybody's washed out. So that's phase D on the bottom. And these are secondary endpoints. Um, I recommend just going to the far right column and look at the p-values. And there's a lot of very significant findings in the secondary. How many people had 30% reduction in pain by week 15? How many had a 50% reduction? How many used a lot of rescue medicine and so forth? And it was very clear that there was a significant difference between those that were on placebo and those that were on the active drug.
yeah, almost approaching double.
Yeah, it's reassuring to see, a dozen or so secondary endpoints all have
Yeah,
sort of makes me more confident anyhow that there's a story here.
no, very promising. All right, coming up, we have adverse events. Teresa, if you're still with us, we'd love you to take us through this slide.
Yeah, so I'm here. Yep, so this is where, as Jahan had said before, the treatment emergent adverse events There was a difference between the two groups. Serious adverse events, there was no real difference. And drug-related adverse events, no real difference. But the top 10%, so you can see that they're much more frequent in the treated group. And that, as Phil had said earlier, some of these adverse events were actually resulted in discontinuation. And dizziness, the headache, nausea, fatigue, dry mouth, the somnolence, all much more frequent in the treated population. And nasopharyngitis was more frequent in the placebo-treated group. So it's just an interesting, there was a time when there was COVID. It's not really statistically significant, but COVID was in greater than 10% of the population reported co being COVID positive. Next slide. Yep.
So, to summarize a part of the study, sort of our first summary here, when we talk about efficacy, this study showed significant, meaningful improvements in pain intensity, physical function, even reports in sleep quality. Regarding tolerability, there were, treatment emergent adverse events, there were discontinuations, but I think that's pretty normal for a study. Nothing that made us say, oh my gosh, this medication doesn't work. Um, and compared to other pain interventions, does this product have advantages and how might it fit in? And maybe, that's a good question compared to ibuprofen. We'd have to look at other safety parameters compared to NSAIDs and opioids like liver impacts and things like that. Moving on to strengths and weaknesses. So, what are some strengths and weaknesses of this study? Well, one of the strengths is that it's an oral product. It was standardized. It's a botanical derived extract or product. Very clear endpoints, detailed analysis of the study product. We don't typically see that with cannabis products. And also large numbers of people. And I'm sure there's other strengths that could be identified as well. As with all studies, there are some strengths and weaknesses to their approach and design and outcomes. There were a fair number of adverse events and discontinuations due to the tolerability of the product, and that could be for a number of reasons. There's no direct comparisons with anything else with the NSAIDs or opioids in this study, and they didn't ask a lot about the effects on cognitive function or driving or work issues or other issues that maybe would underlie some of the discontinuations. And there was a lot of loss to follow up, but again, it's a year study using a product. It is a long time, weeks and weeks and weeks. But that is one of the issues is that they did lose a lot of folks over the study time for a number of reasons. And I'm sure if you take a moment to read, you'll find lots of holes to poke and nits to pick in this study. So, as a friendly reminder, cannabinoids can help some patients, but may be associated with adverse events and discontinuations of using the product if they get frustrated or perhaps become pregnant or have other issues related to the medication. So, in summary, overall, this is a well done randomized controlled trial, provides evidence for benefit, and the benefits come at the price of adverse events and tolerability issues and discontinuations. But this is in alignment with previous research. And I think maybe it doesn't quite align or it's discordant with common patient perceptions and assumptions about the efficacy of these products. Now, some take-home assignments for those of you watching this. Think about your own take on the main findings. Think about how this publication adds to our knowledge base on this topic. Is it worth every journal in the country writing another review on pain to see how this one pain study influences the meta-analysis? Will it change anything regarding your perception of the role in cannabis in pain management? Here are some prompts to help you. Do you believe the results of the study? Um, you know, do you think this is convincing evidence and a significant addition to the state of the art regarding cannabis and pain? As a healthcare professional, do you expect you will mention these results to patients or others who ask your opinion about the topic? Or does this bring up more concerns about whole plant derived products? Further homework assignments to think about is you could complete these sentences, right? A unique aspect of this report is, or I believe the study is important because. These are all great ways to start a discussion about this paper. But if you're interested in this, there is a lot more research out there. There are many ongoing studies. There's lots of hits on PubMed regarding cannabis and pain. Here are a few examples. There's studies that have been published on cannabis combined with oxycodone. There's alcohol and cannabis use for pain management, and other studies on full spectrum cannabis extracts for the treatment of chronic pain and open label studies. Our next journal club will be Tuesday, January 2026 during Dry January, and we'll discuss a study on the acute effects of cannabis on alcohol craving and consumption, a randomized controlled crossover trial where researchers designed a bar to fit inside a lab to study people who were dosed with cannabis products and then allowed to either order a drink or get $3. It's a very interesting study, and we look forward to sharing that with you. And if you've made it to the end, why not fill out a questionnaire? Scan with your phone now and help us improve these sessions. We also have a free adverse events reporting tool available. Scan this to learn more, or you can visit the website and contact us there. All right, thank you so much. And if you haven't visited our website, you can sign up for a free membership, get access to free blogs about educational research. And we look forward to hearing from you and seeing you again in one of our journal clubs.
Thank you.
Gotcha.